Good afternoon, everyone. As Mark said, my name is Stacy Fredenberg, and I'm the Communications Manager for the South Dakota Foundation for Medical Care. We're the Great Plains Quality Innovation Network, and we're excited to be partnering with the South Dakota State Medical Association to offer a 10-part series of webinar briefs. Key patient-centered care topics will be presented in 15 to 20-minute webinar segments, highlighting provider and clinician perspectives while introducing corresponding resources and tools. Today's webinar, Helping the Patient with Diabetes Be Realistic, is focused on engaging the patient beyond the exam room. Most struggle with making and breaking habits. Explain the benefits of a change is the first step, and determining which intrinsic motivation will lead to a patient's success is much more difficult. This webinar will provide basic communication tips for gaining trust and increasing compliance. So I'd like to introduce our speaker, Dr. Eric Johnson. He's an associate professor in the Department of Family and Community Medicine and Education Resources at the University of North Dakota School of Medicine and Health Sciences. He serves as the Director of Interprofessional Education and Medical Director for the Physician Assistant Program. He's head of the University of Nebraska-Kearney with a BS in Psychology and received his MD in 1989 from the University of Nebraska Medical Center. Residency in Family Medicine at the University of North Dakota Fargo program. Dr. Johnson is board certified in family medicine. He's currently president of the American Diabetes Association North Dakota affiliate and president of Tobacco Free North Dakota. Thank you, Johnson, for sharing your knowledge and expertise with us today. I'll turn the presentation over to you.
All right. Thank you, Stacy and Mark, for that introduction. For those of you who don't know me, I have had a diabetes, almost exclusive diabetes practice for about the last 20 years here in Grand Forks. Really got involved with diabetes care, and I got diagnosed with type 1 diabetes as an adult. So I often have patients tell me that they think I have a little bit different perspective on some of their barriers. I'm going to try to share some of those insights with you today. Ours are to relate common barriers through personal experience. I'm going to talk a little bit about some communication techniques for shared decision making. I'm going to focus on some American Diabetes Association guideline-oriented material that addresses barriers and psychosocial issues, in addition to some material from the National Diabetes Education Program that I think is pertinent here. I've been on some advisory panels and some speakers bureaus. I am also a speaker for the American Diabetes Association National, and I serve on the Primary Care Advisory Group for the American Diabetes Association. I'd like to start out by saying that from a personal perspective, I find diabetes is very boring and can be very tedious. And really communicate this to patients early in our relationship because I want them to understand that diabetes is a very tedious process. It really takes up a lot of our time. It's almost like having another part-time job sometimes. And having excitement with diabetes, that's usually not good. That usually means that something bad is happening. So I want to kind of get through this barrier right away with new patients who are newly diagnosed or are seeing me in our diabetes center for the first time. Patients have barriers to success with diabetes. I don't think that that's really news to anybody on our WebEx today, but I quite often find that these are life issues, really not diabetes issues. Something's going on in their life that is preventing them from having some diabetes success. Or maybe they don't have exactly the right program for a particular individual. It's a wrong program, or it's beyond their capability. And American Diabetes Association actually has direct language in their most current guideline about individualizing therapy, make sure that we're not reaching beyond a patient's capability to manage a complex regimen, and some things that we can do to increase success. We don't necessarily increase treatment burden. It can be an extremely difficult balance. Many of you have heard of motivational interviewing. I think this is still a relevant practice for dealing with chronic disease management patients. Diabetes, be it congestive heart failure, any other chronic disease where we feel like we really need to help patients move along through barriers, get those barriers identified, try to decide what is the best way to work that, and then move on. And I think an important component to this is make sure that we're not overloading patients with too much information. When we see a patient in the clinic for diabetes or another chronic disease, quite often what we see is a bunch of numbers they need to be addressed right now. So in one visit, we might about addressing A1C, we might think about addressing blood pressure, we might think addressing weight or BMI or a lipid profile, and that's just overwhelming for the patient. They hung up on a particular thing, and we help them identify barriers. They may not even know what they are, but this is our opportunity to do that. And sometimes we might think that's not a very time-efficient approach, but many things I do with electronic health record that manage these things very efficiently so that I can address what kind of questions a patient might have at every single visit. Motivational interviewing really is a particular kind of conversation about change. It's identification of barriers and helping patients to understand what they might need to do next. We facilitate behavior change through resolving ambivalence. We think we see a lot in chronic disease, particularly with diabetes. I help them increase importance of what their input is or what's happening with them. I help them to understand that what with them really is significant. And obviously, everybody on this call understands what bad outcomes are like in diabetes. But we'll help patients build confidence. In diabetes care for almost 25 years, but I really didn't get familiar with motivational interviewing until about 15 years ago when I was involved with a state tobacco cessation program here in North Dakota. And I went to Mayo for a training that was motivational interviewing based. And I really found these tools to be quite helpful. And I'm trying to distill this down for most of our listeners today. Basic motivational interviewing, it's not like raw, let's get motivated. It's really helping us accept patients where they are at. What are they capable of doing today? A is different in chronic disease. Patients have a few days a week where they really excel for whatever reason, and they have other days where maybe they are not. We also need to understand that we might not be the expert on patients' life circumstances. We may be asking the right history questions or review of systems questions. So we really not know what's going on with them. And some patients won't really volunteer what's happening with their life. And sometimes when I see changes in diabetes are adverse or negative, that's something to go to first. Is how are things at home? What's going on at work? We can identify some issues there that we work through, and that will actually help improve the patient's status. We acknowledge that the patient may have some of the answers. Ask patients, what do you think we should be doing next? That's usually the first questions I ask them, particularly know them well. If it's who's new to me after I've completed their history and physical, that's when I ask them, why here? What do you think we're doing here? And most actually have an answer to that. Share some responsibility with the patient. And there's a lot of ways to do that. We're using more and more population health tools which reach a great number of patients and helps them make better informed decisions. We have a medical home program that allows patients to give us feedback on a fairly regular basis through a nurse. So there's lots of different ways to do this in your clinic that can be time efficient. You know, in primary care practice, we maybe have 15 minutes with these patients, and we make sure that we're using all of the team members to maximum benefit. Let's go to a case now that we've had some of these introductory concepts. I think will be a patient type that many of us will be familiar with. This is somebody who tells me they are quote unquote too busy. The 56-year-old female with type 2 diabetes of 10 years duration, non-compliant when she got sent to our diabetes center, with an A of 8.7, known hypoglycemia, and very infrequently tests her blood sugar. She's 5'10", 252 pounds, BMI of 36, and has known cardiovascular disease with an LAD stent. She has significant renal disease, but her microalbumin is normal. She has no albuminuria or proteinuria, and she has a fairly deranged lipid profile, and her blood pressure is not well controlled. So on physical exam, has loss of filament and vibratory sensation in her feet. So she really has several diabetes complications at this point for the course of 10 years, and still fairly young, but she's got a very large BMI. Her A1C is quite high, thus which daily blood sugar well into the 200s or beyond. She has coronary artery disease, kidney disease, dyslipidemia, hypertension, and so she has both macrovascular and microvascular complications. Her medications are pretty typical, I think, for a person with type 2 of this patient. Metformin, glipizide, sitagliptin, and basal insulin. With the note, she's occasionally missing doses of insulin. I think this happens a lot more than we think. If patients miss a dose, they really don't know what they're supposed to do next. They don't have a good strategy for that. If we've told them before, they don't remember. And missing one dose a week of basal insulin, difference of 0.3 to 0.5 in the A1C. Most don't attribute that much significance to it. This patient have up-to-date visits with other members of the team that would be helpful. She's a licensed registered dietitian at diagnosis. The problem with that is she has had heart disease in the meantime and has had no dietary update with respect to that. Her tension is probably has some dietary components we can address, and so her BMI. And though she saw CDE was at her insulin start. This program is, quote, walks when the weather isn't bad, unquote. Her son is divorced, full-time job. They heard that sedentary jobs are the new tobacco as far as heart disease. Sitting at your desk all day long really promotes heart disease fatality. She doesn't use tobacco and notes occasional wine. Her diet review of systems is no chest pain. She has some dyspnea with activity. That would cause me to wonder if her heart disease is maximally treated. Paresthesias in her feet consistent with her physical exam, and also notes knee and hip pain characteristic of osteoarthritis. So we'll cover later, but we'll talk about helping patients to feel more connected to their own care and their own diabetes. Just the little things. I can't always be about with patients what's going to happen 10 or 20 years from now. I tell patients about future complications and what strong predictor A1C and blood pressure are for those future complications. But we can always be talking about what's going to happen in the future. So we need to deal with what's in front of us right now. And this has a lot of potential issues. Might be keeping her from being successful that would be reversible in the short term. We can all at once. Maybe there's one or two things we could do today to help her build some confidence and success. And that might be a great place to start. And maybe this is going to be over the next several months or even a year while we try to get her back in a good spot. A little bit about the National Diabetes Education Program. And I'm going to use some of these slides that are really patient-oriented. But I think us reflect on the kinds of things that maybe we should be saying to patients, or hopefully if they're familiar with these materials, they're going to be able to come back to us and say, what about this? What should I be doing here? Oftentimes patients will come back with information from the internet, but it's not from good sources. This will be an example of a really good source that we could point patients in that direction. So it's a great slide. How can the patient learn more about diabetes? And this is directed to the patient. Class to learn more about living with diabetes. Often, local healthcare systems or hospitals will have these programs. I medicine with a clinic in Rugby, North Dakota, a diabetes telemedicine clinic, and in-house class for persons with type 2. And it's very well attended, it's very dynamic, and a really good way to offload some of the workload trying to cram all this into a clinic visit. So patients engaged, and you have somebody who's really enthused and committed about leading this can be good. And this is paired up with a support group. And give patients online resources to that so that they're just not Googling things. You're not going to get good information that way. I direct to things like the CDC page, which is the National Diabetes Education Program. I often direct patients to the American Diabetes Association webpage. And the thing about web pages is they update information every time there's something new, which is a little better than print materials, I think. We understand that they're a critical member of the healthcare team, and I know that, but I don't want to overload them with too much responsibility or information. I think I should give them as much as they can handle, and not be the same at every visit. But we emphasize that you have a team that you can go to. If I'm available, they know that they have their diabetes educator. They have a relationship there. We have a practitioner in our program who also runs a medical weight loss program. Far more and more involved with diabetes education all the time. I know the pharmacists in my community who do a lot of this, and patients who go there, I actually encourage them to use that resource. That's a great place to go with any questions or confusion about medications or how to take them. I want them to understand that they're not all alone, or that they don't just have one provider, have a team who is available to them to help them answer their questions at any time. And with a team-based approach here in Grand Forks, our members talk to each other all the time. If a doctor or dietitian gets a call from somebody or they see them in the office, will message me electronically if they need a more urgent turnaround time on a question. So we do a lot of team-based care through our electronic medical record. Then the care of your diabetes. And if you look at this slide, this is a lot more about more immediate concerns. People with controlled diabetes are fatigued, and they often think it's because they're working too hard or because they're getting older. It's because they're hyperglycemic. I promise patients that if they get their blood sugars better and they let me help them with that, their energy level is going to be better. They believe that, but they almost always come back and tell me that they do. They're also going to be urinating a lot less, especially overnight, and can really help with their energy level too. So it's about things that are right in front of us right now. I love this because these are action steps that anyone can take care of right now. When we're looking for a healthy meal plan, that doesn't necessarily mean wholesale changes with a diet plan. That's not drinking regular pop. It might mean eating some of the things they like, just less of them. It might mean eating slower. Kind of some quick fix things that we can give patients right away while they're going to move forward with a better quality of life. How can they be more active? I think this is a significant issue for the patient I showed you, and it's very common of what I see in practice in Northeast North Dakota. People are active if the weather is good, which is probably 8 months of the year. So to hear people tell it, it's like it's all the time. And the patient has osteoarthritis, so walking is a really poor choice for her. I think blood sugar is a critical piece too. I don't think that more finger sticks is necessarily better. Doing finger sticks at the right time is what is important. A 2-hour post-meal can be very helpful to me. Sometimes that's the blood sugar that gives me the most information. Talk to patients about strategic testing, and they sometimes can do a little bit less that way, and they feel like they're not so overwhelmed with testing all the time. especially hyperglycemic. A lot of people quit testing because they're seeing high blood sugars. I have people with diabetes to take it seriously, and they will do anything to not have cancer. They get diabetes and don't really have it. They just don't. It doesn't have the impact on them. They think it's annoying, or they really know what can happen with this, but it's going to be fatal for a lot of patients. So I understand that what we do now is going to make them feel better now, but we're going to be having a better conversation in 15 or 20 years. And that's where I'm at in my practice. The patients got that, or figured eventually, are the ones who are still here and coming to appointments. And I really addressing that is an important piece for patients, because a lot just don't know. This patient, she has many potential barriers. She's divorced. I don't know what the situation was with that. May have some financial issues. I saw it with patients. And is it something like their formulary on their pharmacy benefit changed in their copay? Well, tell me that. I don't necessarily know what to do with them. This says for chemical dependency, I'm perceiving that this is a vague alcohol history. I told a bit about walking for this patient. Does a bad weather plan. Has osteoarthritis, so we need to address that. It's the same in South Dakota as it is in North Dakota. Lots of small towns now that have these 24-hour-a-day fitness places. And it doesn't matter what the weather is like there. And some of them are $10 a month. I encourage people to be seeking out other opportunities. This might have mistaken impressions about when and how to take her medications. Maybe when...
But I'm supposed to be about patient motivation. Thanks.
Okay, hold on. We have some background noise coming in. If you're on the phone, please mute your phone.
This patient is mistaken about when she needs to take her insulin, and maybe that's why she's missing doses. That's something that we could work with on somebody. A lot of this is workflow analysis. What is their day like, and how to help build some of their diabetes activity into their workflow. She might have a dated, difficult to use or non-covered meter or strips, and notes that the meter is never where she is. So that's a big issue for patients. The patient was actually using vials and syringes, which is a very dated strategy. Most patients have no trouble with pens. It's quite easy for them. Her conditions like heart disease might be taking priority for her or create confusion about her diabetes management. She doesn't fully connect those two. So cardiovascular disease is the #1 killer. She has time management skills. She always seems to be in a hurry with everything. That tells me that we need to teach this person some time management. And she, quote, helpful advice from family and friends and has insufficient internet skills. I've done some pertinent American Diabetes Association recommendations related to some of these barriers, and then we'll up for some questions. Recommendations are that treatment decisions should be timely and based on evidence-based guidelines that are tailored to patient preferences. We need to consider the burden of treatment and self-efficacy of patients. We need a thematic approach to support all of these things with patients. We want to support behavior change. There's lots of ways to identify barriers and work through that, as we've already noted. Diabetes Association put out a specific position statement on psychosocial care in Denver. I'd encourage you to look that up. Here are some of the things that they recommend for routine follow-up, and I think affect in mood is huge with this. Talk about the concept of diabetes distress. This is very common, and not depression or anxiety. These are psychological reactions related to managing a chronic condition. And a patient's diabetes is a second or third job and necessitates time management, not necessarily us making their diabetes more complex. Do and don't do for patients. I find what's important right now, what they think is important. I want a symptom that maybe we can improve in the short term. Sometimes a medication change to a medicine that would help with weight loss or a new meter can be energizing. I do it on my computer and electronic record until I've visited with the patient for a few minutes, and I usually look at logbooks and meter downloads closer to the end of the visit. I want patients to think that they are only numbers. I add changes in costs. I explain what dietitians and educators actually do. And type 1 patients, they're tired of talking about diabetes, but they'll talk about technology all day long. I think success is good life management. I think success is connecting more with their diabetes, not trying to separate themselves from it. We need to be linked to individual treatment guidelines. One size does not fit all. Baby steps is kind of a cliche, but it's absolutely true. And get overwhelmed as a provider. Some patients are just never going to get it, and we need to accept that. Have for today, so I'd be happy to open it up for a couple of minutes for questions.
Just a second here, I'm going to go ahead and unmute the phone lines. I believe all phone lines that have been unmuted, so please proceed. Once again, all phone lines have been taken off mute. Do you have anyone have any questions for Dr. Johnson? Okay, see, hearing no questions, would you like to discuss about the next program coming up?
Yes, the next webinar is on May 9th, and it's tools and resources. It's going to be on self-management education programs, and Dr. Johnson's going to provide information on that as well. There's been evidence to show that those who participate in that kind of activity are able to make some of these changes that Dr. Johnson was alluding to through a group environment. So it's just another resource for that as well. So thank you to everyone who participated, and we appreciate your time, and thank you, Dr. Johnson, for sharing your insights with us today.
Welcome. I'll see you in a couple of weeks.
Thank you.